Welcome to the Real Integrative Medicine Podcast. I'm Dr. Jordan Robertson, and I'm here to bring you the tools, insights, and strategies to take your health to the next level while using evidence-based integrative medicine. What's real? This is what we want to explore together. Research is ever-changing and not easy to interpret. We're bringing you the best that integrative medicine has to offer while sticking to the facts. Our mission is to elevate the practice of integrative medicine for clinicians and patients alike. Preventative solutions, nutrition, exercise, and sometimes supplements have a seat at the table in medicine, but only if we uncover real science-backed solutions. It's time to uncover what works and challenge what doesn't. Let's unlock your full health potential with an integrated approach. Ready to learn what's real? Let's dive in.
All right, guys, I'm so excited for us to have this episode today of the Real Integrative Medicine Podcast. I'm joined by one of my friends, colleagues, Dr. Ashley White. And I think that this is going to be one of those conversations that becomes like this monumental, landmark podcast episode. We're talking about appetite. We're talking about weight management. We're talking about medication, kind of answering all of the unasked questions about this conversation. I'm so excited that you're here with me today, Ashley. I just think you're so brilliant and have so much to share, and I'm so happy to share the mic with you today.
Thank you. I'm very, very humbled to be here as well. This is a big deal. Thank you.
So Ashley and I actually go like pretty far back. Which if you are connected with me on social media, and I'm going to encourage that you follow Ashley as well. We have actually just started working together like in a more like sort of clinical sense, where Ashley has joined my practice in Ontario, Canada. But we actually have a history that's like stems back, I don't know, is it 20 years at this point, Ashley, where for a period of time, spent time on an emergency response team together at university, where we like slept in bunk beds, responded to all of the medical emergencies on campus. And after that point in our lives, separated and didn't, hear from each other, even know what each other were doing for so long, and got reconnected this past summer, which has just been like an absolute joy for me because you're such like a high level leading woman that I admire. And so I'm so excited that we spend so much time together now.
Yeah, same. It's not, it feels a bit like destiny. So I'm very happy that we were able to cross paths again, for sure. It was because of a Facebook ad, which you're very good at. So well done.
A Facebook ad. That's right. I target marketed Ashley.
Yeah. I was like, wait, is that Jordan? What's happening here? And then I was like, there's a whole world out there. I didn't know. I had no idea.
Yeah. And so in our time apart, which was many, many years, you had a pretty interesting journey to get to this point where you are in your career now, which maybe we'll save 90% of that backstory for another day. But the part I want to hear about is how you got so interested in obesity medicine, appetite literacy, and what we're kind of coining as like metabolic strategy with patients.
Yeah.
How did you get so interested in this, and how did that spark this passion for you for this to be the way you're going to change the world?
I'm not exactly sure why, but I started reading diet books when I was really young. So like 10, 11, 12, I started actually learning about, sometimes they were just straight up diet books, but sometimes they were like nutrition science and nutrition physiology books. I've always been interested in food as fuel, and also interested in sports performance. Sports were really important to me for a long time. And always identified my body as a bit different than others because I was in a larger body, especially as a teenager. And so I was always trying to figure out like the system, the hack. And, anytime I had an opportunity to learn about nutrition or health or food, I took it, even prior to several other things happening in my life that we can talk about another time. So that's always been both an inherent curiosity and also, I think, a reflection of the fact that I was raised in a family of some really large people who struggled a lot with their weight, and weight struggles were part of the everyday conversations in my life for a very long time. And I found myself later studying addiction and public health, and also working in policy around public health. And obesity was actually almost started a PhD on obesity and social networks, and that would have been in epidemiology. I didn't end up doing that. But obesity is one of those things that we used to talk about in public health as a wicked problem, which means everything matters and no one's in charge. And it felt really difficult and futile. And then fast forward to my first several years of practice, realizing that I cared for a lot of people who had a lot of metabolic disease, and telling them to lose weight based on what I knew was just a terrible idea. But it's really what I was told to do in my learning. And the line that got me here is not straight at all. But here I am doing what feels like a full, robust version of the work I was meant to do, for sure.
I love that. And it's so common that people have just this kind of like personal story with their, whatever it is that their passion is in medicine. When, like, it sounds like, and I would love to kind of hear just a little bit more about, like, was there like a particular aha, like you were working like family medicine in a small town, and like, was there a particular moment where you were like, I need to be the person who changes how this is done? Like, how did you like get to that point?
Yeah. So I was a patient. After my first child, my daughter was a little over 1, and I was working far, far too much, and my weight was going up and up and up. And I had previously managed my weight with movement and with caution and just being younger. And, you know, and certainly at some times I've managed my weight in ways that I would not advise a patient to do. But I enrolled in a medical weight management program early in 2021. And I was treated like I was a person who was obviously experiencing appetite dysregulation. And I was obviously experiencing a clash between the needs of my brain and body and the world I had constructed for myself, which was a high pressure, rural emerge. I was rural family and rural emerge, and I was working a lot, and I was postpartum, and I could not regulate my appetite, and I was working a lot of shift work, missing a lot of sleep, and really struggling to figure out what my body was doing. And I was at my highest adult weight, and so I was treated appropriately, like not completely. I would say there's things that could have been done better, but I had this moment of relief from the constant dysregulation, the constant conversation with my appetite that was constantly asking me to soothe myself with food or avoid something uncomfortable with food. And I experienced relief for the first time ever. And through a combination of medication and some therapy. And I thought, well, this is just the beginning. I knew instantly the minute I woke up as though I was into someone else's brain. I was like, this is just the beginning. There's way more to this story. And since then, I have experienced the world in a lot of different bodies, and I experienced feedback from the world in all sorts of different bodies. And I have run the gamut of the kinds of things people experience in larger bodies. There's a lot more to know than just you need to go on a medication that's going to quiet the noise. There's a lot more to understand if you're going to do lifelong weight and appetite regulation well, in a way that serves your goals and your purpose. So that's when I first started to say, okay, well, I need to reverse engineer the process by which allowing people appetite regulation such that they can then go and accomplish bigger things and improve their health in the following ways. That's when I knew.
Do you know what I was dying for when I was a practicing clinician? I wanted someone to summarize the latest research, tie it up with a nice little bow, and deliver it to my inbox every single month. I'm Dr. Jordan Robertson. I'm the host of the Real Integrative Medicine podcast, and this episode is brought to you by my free integrative medicine magazine called The Stacks. We're all dying for unbiased, unindustry funded information to help us be the best in practice. The Stacks delivers you quality articles every single month on the latest research on things you care about in practice, as well as opinion articles and business advice for integrative practitioners and naturopathic doctors. You can subscribe to the Stacks with the link in the show notes today and get access immediately to all of our back issues that show you exactly how to be an evidence-based practitioner. I hope you sign up and you'll enjoy it. You said such important things there that I just want to backtrack on because, your life. No, but this is so I'm just saying it a second time for a listener that you're talking about your life, right? Like the shift work, the postpartum, the overworking, the high stress, and that became part of the dysregulation with respect to appetite. And it's so common that, as I'm going to say, especially women, but lots of people, but especially women, would normalize so many of those aspects of their life and then feel like they needed to white knuckle their way through appetite regulation, right? That was this moral issue that they had where they couldn't be good enough, with respect to appetite. But you painted this beautiful picture where everyone would say, yeah, of course that would be really difficult. And made that connection with your appetite. Like most people, I don't think would be able to do that. See how their environment was becoming part of the stage like that, which their appetite was difficult to manage.
Mm-hmm. And I'm lucky because there have been times in my life where I have felt more regulated than others. And so maybe I was just more sensitive to it. But also I have since come to understand that I have a genetic variant that means that I'm exquisitely sensitive. So once I opened the lid of all of this, you do get down to the DNA at some point. And I had a very powerful response to pharmacotherapeutic, a medication intervention that I was so obvious. It was like a horizon lifting. It was like blinders had been taken off. So I had a dramatic response that maybe I was a bit more sensitive to because of my work than other people. But this goes to show you how complex it is, because lots of people start weight loss medication and they notice nothing at all. And I think that right now we are at the beginning of understanding how to help people with weight. And it's actually not how to help them with weight. And what I find is there's this weight story, which brings people in the door and starts the conversation. And under that, there's a metabolic story, which is actually usually pretty messy and tangly. And then under that, there's the story that we've been telling ourselves about that metabolic story. And usually it's a story of willpower, like you said. Usually it's a story of, I just haven't worked hard enough. I just have a slow metabolism. It's my thyroid, yada, 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 yada. And maybe, but most likely it's not willpower and it's not your thyroid. Most likely it's a combination of a bunch of things on top of a genome that may or may not be very supportive of weight regulation, on top of an environment and a culture where we have a food environment that is engineered for your excitement. And one person's willpower cannot stand up to that. We have billions of dollars in food marketing that are trying to get you to use food to solve all of your problems. And it can't. I wish it could, by the way. Just can't.
Well, I tried with a carrot cake that my mom got for my birthday a couple of weeks ago. It's still...
It didn't. Yeah. The bottom of that pan didn't have all the answers. I did.
I have all the answers.
Yeah.
But I think for you to call it out, and again, that piece around your environment and the influence that I want to talk about the environment side. And then there's the genetic side, because I think both of those pieces we've not put enough emphasis on. And so, and then it does come back to well, who are we blaming if, right? Or where does the blame fall? And for some reason, we're always looking for someone or something to blame. But that environment piece, we could say to patients, if you're not sleeping, you're gonna, your appetite drive will be higher the following day. And it was always so interesting to me in clinic how easy that was to brush off, right? Patients would be yeah, okay, right? But I should still be able to, I should still be able to manage it, even if I didn't sleep well. And I'm no, we literally, no, you don't, you literally can't. If you don't sleep, you will eat 300 extra calories tomorrow. We just know it. And yet that still was something so difficult for people to accept. and if their food environment or even like their family structure meant that other people were being involved or influencing that food environment, you're like, well, I should be able to sit beside my partner while they eat Doritos and I'm not going to eat anything. And we're like, no, that like literally eventually doesn't work.
It just requires far too much energy and effort.
So much. And it's what happens if we can put some of that down, right? Like if we can put some of that, like, trying to push a boulder up a hill feeling, whether that's through medication or changing the food environment, but it's not easy to change people's food environment. I don't think. No. After years and years of trying to coach people through it, it's not like people just needed to clean out their pantry and then they would suddenly find success.
No, and I think I was ahead of the game in that I had dieted so much and I had done every single, like I was a raw foodist for a while. I have done everything, the zone, friggin' all the time. And so I knew very well that it was not an information deficit, that whatever I did in the realm of weight loss, even back before when I was sort of a more typical family doctor, it was never just like, oh, just do this. Because I was like, I know very well that does not work. And I know very well because that's my life. And I grew up in it. So the food environment is not simple to modify. And then, we can talk about the ecosystem of the family home, but we can talk about the ecosystem of the neighborhood or the policy ecosystem that governs food additives and endocrine disruptors. Like we can talk at every level, which is why obesity is so tricky. And it's linked also to, the way that other health issues manifest in terms of autoimmune disorders and inflammation and metabolic, like it's all related. But at the core of it is there's a bunch of things that make it really easy to gain weight and only a few things that make it possible to lose and sustain the loss of weight. And we are all a little bit uphill. And after working shift work and working far too much with ADHD that was undiagnosed and unmanaged and a genetic propensity for appetite dysregulation and obesity, I think that there was a time when I thought, oh, this is just me. This is just all of my inner faults being revealed. But I realized actually, no, that doing that for over a decade actually changed me. It changed how I experience joy. It changed how I experience everything. And there is now, and the reason I'm doing this work is because I do want to give women in particular permission to say, oh, in order to solve the weight problem, I actually need to solve a lot of other problems. And they have to do with the stories I tell myself and the stories that other people around me are telling me. And they also have to do with how my body turns food into fuel and how it disposes of that fuel. And actually all of that matters. And that sounds extremely complex. It's actually not. But it requires a strategy, which is where this idea of a metabolic strategy has come from, because that's actually what I do. And that's what I think people fundamentally need. They don't need just like a script for a GLP-1 receptor agonist. They need a strategy that reflects their own individual variables personally.
Yeah. Can we talk a little bit more about just that genetic piece there? Because I think, and this was something that when you and I started working together that I really hadn't spent a lot of time on myself. I've like when something's new to me. And so talking a little bit about like that genetic variation, like when we talk about obesity being genetic, like what part of it is the genetic part? And like, how does that play into what we now understand about appetite regulation?
Mm-hmm. So the really black and white answer is that there are several monogenic obesity syndromes. So these are obesity syndromes like Bardet-Biedl syndrome, which is the most common of the very rare, POMC deficiency, there's leptin deficiency. These are things that are usually autosomal recessive genes, disorders that show up and they cause marked hyperphagia as early as age 2, and they cause high weights as well as a number of other anomalies, like depending on exactly what the disease is. And so some of my patients have those, and they are marked cases. Now, that's a small number of people. Then there's the rest of us for which a few genes turned on either in a inherited pattern or an epigenetic pattern or a spontaneous pattern, all together determine body size, height, width, bone mass, determine all sorts of things that help regulate body size and metabolism and appetite. So we have this sort of stew of genes that we think contribute to the ultimate size that a person is going to end up being. Now, in a calorically restricted environment where, our populations have faced famine and food insecurity, obesity is not the sequelae of that. Whereas we are now in a modern food environment that reflects a very short period of time relative to like the length of human history. And those genes are now clashing with the fact that there's a caloric surplus everywhere we turn. Yeah, everywhere. Every gas station is a caloric surplus. And this isn't to say that calories are bad, but if we take a how do I fuel myself for the life I want to live mindset, it's like, oh my gosh, of course my genes want me to gain weight because that means they're hardy and good. And I have the ability to accumulate weight and I have the ability to accumulate fuel and store it for another day, which is marvelous, except for now where we have too much. So that's the genetic piece. Now, yeah, sorry.
No, I was going to say, and then just to follow that through line there around appetite, like what I've heard you say and what I think is really valid and important to share is that it's not a on off switch with some of those genes. There is a spectrum for how those things are experienced. And that's why we're maybe needing to have this more individualized conversation about how we manage these patients or how we manage ourselves, because the way that our body is and brain are going to show up in this high calorie environment is different than somebody else's, and that has nothing to do with our emotions or our willpower and has a lot to do with how things are wired.
Yeah. And this comes down to this idea that some people are really hunger tolerant and some people are not. So there are some people who just don't find hunger painful and distressing, and they're very sensitive to changes in levels of leptin. So a slight drop in their level of leptin and they will experience hunger that is difficult. It's difficult for them to think about anything else. And for those people, losing weight is really hard. Any caloric deficit that they try, any restriction that they try will be met with pain and suffering. And so weight loss in that context is much harder than for someone who is more hunger tolerant. They don't feel it as intensely, emotionally, cognitively, physically. It's just not as hard for them. So they can sustain a caloric deficit for a little bit longer and usually have more success with weight loss just through the dieting approach. Even that has its end because caloric restrictions are hard to maintain for a long period of time. But those genetic variables explain why we see some people who just don't tolerate diets. Yeah.
And how does emotional eating fit into this, right? And because there's lots of spectrum around emotional eating, and there's even diagnoses that are trying to capture some of those emotional eating definitions. How does that fit into this conversation, or does it?
Yeah, so emotions are one of the ways that our appetite manifests itself, either with irritability or just you think about someone who's becoming hypoglycemic, they can look a lot of different ways. They have physical manifestations. They may sound confused. They may say words that don't make sense. And then they also may look panicked. They may have emotional story that is being told with hypoglycemia. So similarly, the human appetite has an emotional expression. The human appetite's also in the deep brain. It's in the primitive brain, which is where most emotions are, originate, I guess, is not exactly the right word, but our emotional life, the emotional experience that we have is a primitive one. It does not come from the prefrontal cortex. Our prefrontal cortex is how we try to modulate and regulate emotions, just like that's how we do that for our appetite. So if we think about the appetite as an expression of the function of our deep and primitive brain, sometimes we can be a bit more kind and gentle to ourselves because it's like, oh, I'm just an animal. Yay. But we also can realize that when we, most of the time emotional eating is attributed to something that women do. And so there is a bit of a feminist lens there that, oh, it's just, if you weren't so emotional, if you weren't so weak, if you didn't have all of these emotions, then you wouldn't have a weight problem because you wouldn't eat in response to sadness. And I think that we do a great disservice to people by saying that emotions are problematic, because they're not, and B, attributing something that we don't know. So when someone has a binge or an emotional eating episode, we don't know their physiologic state. I don't know if they are tired. I don't know if they're hungry. I don't know anything about that time unless we're tracking. And what I've come to see in my practice is that whenever binge eating disorder is diagnosed in someone with PCOS, magically, metformin tends to make it go away, which really makes me wonder if that's an appropriate diagnosis, because metformin doesn't treat emotions. It is not a psychotherapeutic agent as far as I'm aware, unless someone has magic information I don't have. So why are we diagnosing binge eating disorder in someone whose physiologic state we actually haven't captured at the time of the binge? And binge eating disorder is a real thing. It is a real thing. And if we're diagnosing binge eating disorder, but that not at least exploring whether there's some sort of insulin dysregulation or a disorder of glucose homeostasis in that person, as there would be in someone who has PCOS, then why are we just caring about a small part of that overall picture? We're caring about a really small part of that person's metabolism. And binge eating disorder is sometimes treated with atypical antipsychotics, which is going to double down on the weight gain, right? So this is so frustrating to me and so in my practice, in my work, like the program that I offer, I just call it big eating. All eating that feels like it's eating past hunger and into wanting. If you're aware of physiologic fullness and you're still eating, we just call it big eating. Doesn't matter what, I don't care. Doesn't matter what it is. And then it demoralizes it neutralizes the good, bad. And it just says, yeah, this is actually part of being human. Lots of thin people eat into fullness. Lots of large people don't eat into fullness. It's a deeply, deeply personal experience. And I think we're missing the big picture here.
So let's shift for a second, talk about the medication options. And I'm curious, there's been a rapid adoption of medication, which I'm actually in favor of lots of this. And I think that I talked about it before on the podcast, how revolutionary it's been for some of my patients I always called it putting down the backpack that they'd been carrying around their entire life. And in that backpack was a heck of a lot of behaviors that they needed to do to avoid gaining weight or to try and lose weight. Like food weighing and all of these things, but then also the entire lifetime of stories that they had about how their willpower or their lack of motivation was the cause. And I always thought that it was such almost like a grief experience for patients to go on medication, because they realized very quickly, it's all similar to your story, realized very quickly that they could put down this entire story that involved their swim coach and their grandmother and all of these people who'd ever told them about their weight, and that they actually acknowledged, I hope for most of them, that there was so much of this that was part of their makeup and not part of their willpower. But lots of just I think people loosely know how those medications work, but I'm curious in the context of our conversation that we're having now, how do they fit in this conversation?
Yeah, so the guideline-based answer is that there are 4 pillars of weight treatment, obesity treatment. There's medical nutrition therapy, which is not restriction. It says if you're going to maintain a caloric deficit, how do you do it in a way that's healthy? There's surgery. There's behavioral interventions, also known as CBT or psychotherapy or any, I like coaching in that pillar. And then there's medication. So it's one of four, right? And for some people, surgery, for some people, all four is what's needed, right? But the medication pillar is taking the world by storm because it opens up treatment to a lot more people who otherwise wouldn't be a candidate for bariatric surgery or simply don't want it. And it's far less invasive than bariatric surgery. So that's useful. So the currently available medications in Canada fall into three categories. One is a medication that simply prevents the absorption of fat. It's also known as orlistat. It is not widely prescribed nor used, and it results in some micronutrient deficiencies, and it just is there for some people. Then there's the category that I think will also expand at some point. These are the category that targets the melanocortin-4 receptor in the brain, which is a combination of bupropion and naltrexone, also known as Contrave by brand. It's a standalone drug in the category of medication that help with appetite regulation, and also LDL lowering, blood pressure lowering, insulin resistance lowering. And these help with people who have a lot of wanting-based eating. And I pull from all the categories when I use my treatment. And I often have people on mixed treatment, especially because my therapeutic goal is to keep people on the lowest effective dose as long as possible. So pulling from multiple categories can help you do that. And then the largely well-known category of medication are the hormonal medications that help with the influence the appetite both centrally, so in the brain, but then also at the gut level. And it helps with, I talk about like tightening the connection between the brain and the gut. And it essentially allows the gut and the brain to hear each other more closely and to experience satiety a little bit more easily and to put less effort into managing wanting and the desire for food. So this category of medication includes GLP-1 receptor agonists like liraglutide, also known as Saxenda, semaglutide, also known as both Ozempic and Wegovy, and now tirzepatide, which is both a GLP-1 receptor agonist and a GIP. And it's tirzepatide, also known as Mounjaro. And in the US, it's also known as Zepbound. And so this category of medication is all about improving the connection between what we call the pituitary and gut axis. And the way that it does that is, we sort of understand how this works. And we see that it works. And there's certainly the gut slows down. So there's like this mechanical, I can better perceive the fullness in my stomach because my gut is moving more slowly. But the benefits go beyond that. And if we, some people are like, oh, this medication only works because I'm nauseous or I want to vomit or blah, blah, blah. It's like, it doesn't actually matter the extent of your side effects. Even if you're a person who experiences none of that, you kind of lose the same amount of weight as the people who have early nausea and vomiting. So it's actually not from a mechanical obstruction. And the cases of gastroparesis, which are reported a lot on social media, are not nearly as influential in, like, if you ask the people who actually practice these medications, like these are not common or even as bad as they're made out to be on social media. So there's that. So the role of overall of weight loss medications is as an adjunct to getting the story straight on like why your appetite is the way it is, right? So I can give someone a medication, but it won't solve their sleep debt. Yeah. I mean, if it helps them lose a little bit of weight and helps improve oxygenation and ventilation at night, yeah, that's great. Super. That's awesome. They may still need their sleep apnea treated. They still may need to work fewer shifts at night. Like they still may need all of those things. So the GLP-1 receptor agonist will help. I think about it as like it can depressurize the metabolic system. It can take some steam out of the canister, but it doesn't solve the root problems. And they're like really important. Like they are like, top 5 scientific discoveries of the past 20 years, I would say.
Yeah, it's interesting. As you were describing the other 3 options, I was like, oh, like this option's like has an economy of scale that we've never been able to manage with how many people are suffering. We would never be able to scale any of the other 3 options aside from maybe like group-based CBT. But again, we're the scale that we'd love to be able to talk about here is the like in the millions. And
You're right.
You actually don't have that ability. And so, it's interesting because I think that this is maybe why it's such a interesting and why the adoption was so rapid. Like if we had a 1-to-1 ratio of CBT therapists and people who had obesity, maybe we'd have an economy of scale and then maybe we'd be like, oh my God, this widespread adoption of CBT for obesity really needs to be questioned. But really, we can't.
Yeah. You're right. You're totally right. It's absolutely. Yeah.
If we raised this like question about like how rapid this is made into market, we don't have that opportunity with anything else. So I find that really fascinating. And where my interest lies with this, and we actually just talked about this with our confident clinicians, is like the rapid adoption means that now we're going to have to like tie up some loose ends in medicine, right? I think we have lots of prescriptions and lots of people having, I'm going to say in air quotes, success. I think we have to be careful with that word because success to me probably is the same as it does to you, where we have a person with positive body acceptance and has improved their food environment and is sleeping through the night and they lost weight. To me, that's success. Where, but we maybe have widespread weight loss, we'll say, with the widespread adoption of prescriptions. But there's some loose ends, I think, that maybe need to be tied up now, or we're going to become aware of these loose ends over the next 5 or 10 years. Like I have some suspicions on what I think that conversation is going to look like, but I want to hear what you think.
Yeah. And this is where my career as an emergency physician, I think, is really illuminating some concerns that I have around long-standing use of GLP-1 receptor agonists done without thought about balance. Like I think if we were to take this idea that the point of GLP-1 receptor agonist medication is to restore appetite balance, and in fact, all weight loss is about restoring balance. So restoring sleep debt, restoring micronutrient deficiencies, restoring iron deficiency is this like big untreated monster in women's health, I think. If we were to help with the perimenopausal challenges that women face, if we were to help and think of GLP-1s as one tool in our arsenal of balance, right? Then I think we would be very attentive to bone density changes that come with long-standing caloric restriction and undernourishing, underfueling. And we would be really attentive to the role of sarcopenia or low muscle mass relative to size and low muscle function. We would be very attentive to those things. But because we live in a society where thin is best, and that paradigm reigns even especially among healthcare providers, that you're all good because you're thin, we then don't think about it in terms of balance. We miss that completely. The conversation is just about getting thinner. It's not about getting more whole, which is actually what I think these medications are meant to do. And they're meant to restore wholeness. And in that context, we are looking at sleep disorders. We're looking at lymphedema and lipedema. We're looking at inflammatory diseases of the liver and the pancreas. We're looking at inflammatory diseases of the bowel, disruptions of the microbiome. We're actually caring about a system that is out of balance, often as a result of like the pressures of modern life, but also some genetic stuff. And so in the emergency room, I see profound frailty. I did a shift on Saturday night. Within the first 2 hours, I had 4 old ladies with hip fractures needing to go to the OR. 2 hours, starting at midnight. And that's what frailty is. These women are now no longer going to be able to live the life that they lived before they fractured, because they won't ever be well enough to avoid falls in the future. One of them was 100, so kudos. But one of them was also like 76. So that's a difference, right? That's a big difference. And then I also see end-stage stroke and end-stage dementia from vascular risk factors, and end-stage gangrene from poorly controlled diabetes. And I see that in thin people too, right? So this is not just like, oh, you're thin, you're fine. Like, oh, actually, no, we have to pay attention, because everything has a potential downstream consequence. And I think, everyone is like gunning for max treatment doses of all of these agents, which I think in some people is absolutely necessary. But in a lot of people, what they really need is an appetite guardrail, and they need the ability to eat to fullness, experience fullness, know what that is, and then not continue eating deep past that. And they also, and when they are eating deep past that, they need to have a language that says, oh, here's why this is happening. I underfueled earlier today. I didn't feed myself well enough earlier today. That's why this happened. Or I haven't slept well in a week because my kids are whatever, right? That I want people to have the language of balance when it comes to examining their own lives. And I think of GLP-1s as one of those tools that if left to run rampant, we'll have all sorts of other problems. And I even think about no one studied this, but I think about constipation is a big problem amongst my patients with so lots of my patients come without treatment and they poop once a week. So they're constipated to start. But then they stay constipated. We work on it, but constipation is chronic. And then, so chronic constipation leads to diverticulitis. It leads to colitis. It can lead to all sorts of things. Your bowels just don't move. And then, you have to have half your colon removed at 65 or 70. And I'm like, well, that's not ideal either. But we're not going to see that data for a decade, multiple decades probably. So managing constipation is something that I check in with my patients every visit, because they're all constipated, but they were constipated before. So it's a hard one. It's a tricky one.
Pun intended.
Anyway, that's a big answer to this question of we need to be paying a lot of attention, but that means we have to think about these tools, not just as a magic bullet.
Yeah. And I think what it raises for me, it's the things I worry about with this, and I think this is such an important conversation. It's there's always two different ways to get the same treatment, right? You can get it the fast, furious, not followed up with, no provider time, right? I think you can probably mail order a whole bunch of things at this point that I really wish weren't, right? And even this is a conversation for another day, but mail order hormone replacement therapy, I don't know if that's going to be the silver bullet that we're hoping it is. I think it provides incredible access, but I think it also puts this undue responsibility on medication to fix a whole bunch of things. And it also eliminates some of our opportunities we have when we see patients to have a prevention strategy for all those other things that you're talking about, right? Mail order HRT does not prevent you from having a hip fracture. It reduces your relative risk, but it doesn't protect you in the way that I think it almost makes it feel like it would. And I think the GLPs, I have a similar feeling that it's going to put pressure on the parts of medicine that we maybe weren't doing that awesome with in the first place, like screening for sarcopenia or muscle loss, helping support balance and sleep in that perimenopause phase, screening for underlying disorder, eating regardless of body size. I think that there's a lot, it's the same things we kind of currently suck at and have the potential to get suckier if we just layer medication on top without the complete strategy where you actually are addressing all of the things. And I get it. If someone's had a lifelong struggle with weight, and we now have this, I really like my economy of scale example, but we now have this option for you that allows you to put that backpack down, that has scale, that you can access. I get that you're probably listening and going I'll worry about my muscles later, right? that's like the least of your worries in this moment. But I think if we always ask ourselves what our deep desire is with our health, it usually comes down to being more functional, not being a particular aesthetic, right? Like we usually say, well, I want to get down on the floor with my grandkids. I'm like, well, that's very different than wanting to be the thinnest. And so I hope that there's more practitioners like you, that there's more programs like what we're building, that there's more opportunities for people to have a deeper experience with their metabolic strategy than just getting a prescription, because that's never really solved anything up until this point, even though I think that this is an absolute miracle that we've invented this.
So it's, and you're completely right. And it feels like, oh man, if we're going to do this right, it requires such a hands-on, high-touch experience. And I believe that in some ways it does. The other side of this is weight bias. And like I work for, I advise and direct a telemedicine platform that is, it's mail order medication in a lot of ways. But one of the things that I get to do by being part of Scale is I get to see a lot of cases, like a lot of cases. And so what it allows me to do is to say, when someone says, hey, I really want to increase my dose, and I see, and the questions we ask them allow me to screen for this, but I see that they've lost already 10% of their body weight in a short period of time. They didn't have a very high BMI to begin with. They were like less than class 1 obesity. And they only eat once a day, which are all questions that we ask them on their renewal. I say, well, I think it's reasonable for you to try eating a couple times a day and see what happens to your intake of really sort of high desire foods, ultra processed foods. Just see what happens. And I bet you'll find that this plateau that you feel like you're on is not actually a plateau. And so by reaching a lot of people at scale, I am able to amplify the language that I use in our practice. So I'm able to say, it's actually really important that you're eating 3 times a day. If you shut down your appetite further, this is going to actually paradoxically make weight gain even more likely. And also this plateau will become more stable. So it allows me to reach people with the language of appetite physiology more. And I have to hope that, and of course, like it's not just a mail order, like we're also building an entire strategy for teaching this and normalizing, like, hey, it's okay to be hungry 3 times a day. It's actually good to be hungry. And this is what that looks like. And we're normalizing keeping doses like nice and low and steady. We're normalizing maintaining a good relationship with your healthcare provider and keeping track of your blood results. Like that's the goal of that. So yeah, you can do mail order really incorrectly, I think. But I think that those companies will probably just try and die. I think that they will fail to maintain a relationship and they will fail to build trust. And that's what's going to happen in any space. My hope is that we can build affordable, accessible, and quality at scale using trust. That's my goal when it comes to like that sort of mass part of my work.
Yeah, I love that. And that's partly why I'm so passionate about what you're building too. I would love, I think you and I could probably talk I think we've actually proven that we can talk for 5 days straight about any topic.
Truth.
I would love for you to share like how our listeners can find you and also what your closing thoughts are. Like, what do you want to leave people with? We went through a lot of things here. Like we talked about, we talked about genetics, we talked about emotions, we talked about, the parts of your brain that drive fueling and appetite. We talked about how it integrates with the rest of the way we think about your health. Some of those important pillars around supporting appetite that have nothing to do with medication, but then maybe everything to do with medication. How can our listeners find you? But also like what are your lasting thoughts for our audience?
Yeah. My lasting thoughts are almost always be kind to yourself and if you're a patient, be kind to yourself. It's really hard. There's a lot of weaponized bias towards ourselves that doesn't serve anyone or anything. And then if you're a provider, try very hard to invite that compassion into your encounter with the patient, because it is where you can break down some of those walls. I find it's very helpful. And then also, this is all gray area stuff. There's a bunch of stuff we don't know. We're all trying to figure it out. But it's very important that we don't throw the baby out with the bathwater on these pretty important molecular advancements. Then in terms of how you can work with me, so our clinic is in Burlington at clarityhealthburlington.com, and I see patients there in person. And then I also have an online program called the Shift Program, and it is at theshift.clinic. And the first module of my program is free and freely available. There's lots of useful tools there, including a protein calculator, a fiber calculator, my basic approach to nutrition, which is very simple, and a couple other tools that you can use to sort of get started. And then you can follow me on Instagram at ashleywhite.md. And that is mostly how you would do so.
Yeah, and we'll put the link to all of those things in the show notes as well. Yeah, we're building a really cool collaborative experience at Clarity, which I'm really proud of, which we're also learning a lot. That in the 6 months that we've spent working together, we've barely even told anybody that Ashley has this incredible offer to collaborate with our naturopathic doctors, but also to have a very intensive experience working with her to achieve like this kind of goal in terms of health. So we'll put all those links in the show notes, but this is it. This is our party where we're sharing what's possible. And I do hope that you go look at the Shift. When Ashley was showing it to me on another day, I was like, wait, this is the whole, like all of this is available for free? So we would be pleasantly surprised at the number of resources that are available there. So I'd highly encourage that you go and check that out. Thank you so much, Ashford. This is just,
Thanks for having me.
Conversation, and probably, I'm sure, not the last time that we'll be chatting through these things, but I hope it gave people enough of a pharmacotherapy, but also there's the human side of this discussion, which I actually think is incredibly important. And so thanks for being here.
No problem. Thanks for having me. We did it. Stuck to an hour-ish. Thank you.
That's it for today's episode of the Real Integrative Medicine Podcast. I hope you're feeling inspired, informed, and ready to make changes that truly support your health. If you found value in today's discussion, don't forget to hit subscribe, share this episode with someone who needs it, and leave a review. It helps us reach even more listeners just like you. Your health journey is personal and it's powerful. Let's keep building on the knowledge to give you the confidence you need to thrive. It's important to remember that the Real Integrative Medicine Podcast is for educational purposes only. Be sure to talk to your doctor before making any personal health changes. This podcast isn't intended to diagnose you, and no doctor-patient relationship was formed by listening. We'll see you next week.